This
Yep.
conference will
Okay,
now be
so
recorded.
my name is Gilad Borisovsky. I'm a staff radiologist from Beth Israel Deaconess Medical Center in Boston. Um, I have collected a few cases for you from the practice that we can look at. So I will present each case, and it will appear as either a picture or a short video, and I will give you a minute to look at it, and then we can discuss and see what it could be. So the first case is the picture. So you have this young patient, and what do you think the finding is?
I would
Anybody?
think you're
Yeah.
either showing maybe a ductal bump or an artifact.
Mm-hmm. Yeah. So if you look carefully, this is the aorta, the aortic arch turning into the descending aorta. And you can see that there's a small bump in the inferior aspect of the aorta. So this is called a ductus diverticulum. Okay. So what is this finding is a developmental outpushing of the thoracic aorta, usually at the isthmus, at the attachment of the ligamentum arteriosum. It is probably because of incomplete obliteration of the ductus arteriosus, and this should not be mistaken for aortic injury. So it's a normal variant. You should not mistake it for that. Sometimes it can develop into ductus arteriosus aneurysm, especially in patients who have hypertension. Okay. So this is the second case. I'm going to show it again. Okay. So what is the finding? Anybody had any idea?
I was thinking catheter-associated thrombus.
Yep, I agree. So this is catheter-associated thrombus, and what is the biggest problem with that? So it really depends on the placement of the catheter. So we can say that it is quite a common complication because we actually have an indwelling foreign body in the vessel. And sometimes what happens is that when it touches the vessel wall, it can irritate it and cause the thrombosis. Usually it's asymptomatic, but this is a thrombus, and it can, of course, dislodge and go with the bloodstream to form a pulmonary embolus. And there is a certain position that would reduce this risk, and this is at the upper cover atrial junction. So again, the main pathophysiology of this finding is local injury of the vessel wall and disturbance to blood flow. And when you have these two factors combined, it can end up in a catheter-associated thrombosis. Very good. So these were simple cases, and we have this case now. I will show this again. So this is a little bit more complicated. I'm showing you the video again so you can notice it. Anybody had an idea?
Is it an aortic coarctation?
Yeah, it
Oh,
is.
dropped it.
So as you can see, it's a little bit difficult to see on the video without reconstruction, but you can see that this is the ascending order. And as it progresses into the aortic arch and then down to the descending order, we can see that there is a small or a short segment where it becomes sort of interrupted, but it's not interrupted, of course. But it is very, very narrowed to a very short segment here. Now, what other findings could support this notion? What other findings would you expect to see in a patient who has a coarctation?
Lateral vessels.
So basically what happened is because we have a narrowing of the aorta, depending on how severe the stenosis is, we can have other findings that actually are collaterals, because what happens is that when we have an obstruction, and it doesn't matter if that obstruction is arterial or venous, the blood usually tries to find alternative ways to get to its destination. So for example, in the abdomen, you probably know that what happens when we have cirrhosis and we have portal hypertension, the blood still needs to go or to get to its destination. So if it cannot do it via the portal vein, it would try to find it via a systemic collaterals, so which we call varices or portal systemic shunts. So the same thing happens when you see the aortic coarctation. So the blood will try to find alternative ways to get to its destination, and usually you can see prominent intercostal arteries. So here it's a little bit difficult to see because it's not a whole picture. But it's definitely a thing that happens. So this patient does have aortic coarctation. So if we look at this congenital heart defect is usually around 5 to 8% of all congenital heart defects, so it's not that rare. And usually it's more common in boys than girls. And if you find that finding, you have to look for other anomalies, both cardiac and extracardiac. So always be in the lookout for other associated findings. We have two types. The first type is infantile and is preductal. So basically we can divide it into according to the location. If it's just at the location where the ductus arteriosus connected the aorta and the main pulmonary artery in uterine life. So if it's before that, preductal, we can have diffuse hyperplasia of the aorta, just distal to the brachiocephalic artery. And usually in the adult type or patients who used to get to adult age, the segment of stenosis tends to be shorter, just like in the case we have just seen, and usually it's in the postductal aorta. And some of the media can be thickened at that area, which creates that stenosis. Any questions about that case? Okay. We have another case here. I'm going to show it again. Okay. What is the salient finding? I'm showing the video again so you can see while you see the options. Anybody?
Can I see it again?
I'm sorry?
Oh, can I see it again?
Yeah, absolutely.
I would wonder if this is lymphoma. It just doesn't seem to be narrowing or distorting the vessels, but it's confluent. I don't know.
Okay, so what are the options you say? You say it could be lymphoma? Or it could
Yeah,
be...
I agree with the options is like a good differential. I would want to look more like at the kidneys and stuff to see if I see any other uh, features like of a retroperitoneal fibrosis or other
Okay,
fibrosing processes.
so you're absolutely correct. So if I had to dictate that scan, I would say either lymphoma or retroperitoneal fibrosis. What would make it easier to favor lymphoma versus retroperitoneal fibrosis?
A biopsy?
But you don't have a biopsy yet.
Oh.
You see the imaging, you're, for example, you're the on-call physician at the 3 a.m., you need to decide, is it lymphoma or is it retroperitoneal fibrosis?
Are there any older studies?
No.
So I don't know. Okay, now I'm looking at the kidneys. Sorry. So you kind of look like hairy kidneys. I don't know. So seeing the perinephric findings, I guess you could say I still personally would report it as, retroperitoneal fibrosis versus lymphoma. I'm guessing this is I don't see everything, but is this an older gentleman?
So, if I had to decide here, and it's really a tough question, and I think it would be difficult to get by without a biopsy for this patient, however complicated that biopsy can be, because it's actually a finding that surrounds a big vessel, and if you puncture it, the patient is gone. So I would say that the main differential would be lymphoma versus retroperitoneal fibrosis. And how can we decide? So it's a difficult task. Now, what's typical for lymphoma is that it's usually a little bit more cephalad, which means it's more proximal in the body, and it usually displaces the aorta and the IVC. And retroperitoneal fibrosis is more caudal to the vena hilum, and usually it doesn't displace the aorta and IVC because it's actually fibrosis. So it will basically anchor the vessels exactly where they're located. It can differ in enhancement. So if it's in the acute phase, because there's a lot of inflammation, it will hyper enhance. So we can see differences, especially if we have the pre and post contrast, we can see differences in enhancement of 20 to 60%, 20 to 60 handful units between the pre-contrast and the post-contrast injection. In the chronic phase, because it is the amount of inflammation subsides and we see mainly scarring, so it really hyper-enhances. So if we go back to the case and we look at the location, first of all, if you look at the finding, it looks like it's a little bit more proximal So it's true that it goes all the way down, but it starts more upwards. But there's definitely diffuse environment into way into almost into the pelvis. So the other thing is, if you look at the texture of the finding, so I'm ready to bet that probably the IVC is somewhere here. And because it's an essentially arterial phase, it doesn't enhance yet. So I think we're talking about something that is fairly homogeneous. It does not enhance substantially, but we don't have the pre-contrast phase here. I would favor lymphoma. And because if you look again, it also displaces the order forward. So you see the space behind the order is not supposed to be. So it's a potential space. So this is something that a conglomerate of something that displaces the ND order. It doesn't hyper enhance, and it starts a little bit proximal. So lymphoma is definitely in the differential, and I think a biopsy, opacity, or combination of everything is definitely in place. But it's a very good discussion, very good. Okay, we're progressing to the next case. And this is a little bit, there's a trick to do here. So there you go. I'm showing this again.
Type A dissection.
Okay. Now, and the real question is not if there is a dissection. The real question is a different one. So, if you have to decide which vessels come from where, what would you decide?
Acute dissection with RCF from false lumen.
Okay, I'm showing this again. Yes, anybody?
Acute dissection with RCF from the false lumen.
The RCA?
Yeah, that would be my guess too.
Okay, so you're correct. So we're talking here about an acute dissection with the RCA coming from the first lumen. So if you read the book, you will see that in the main discussion about a dissection beyond type A, type B, or anything like that, it's usually that the true lumen enhances better than the false lumen, which makes sense because the true lumen communicates with the real lumen of the vessel. And if you look carefully in that in the video, you see that this is the dissection flap, and it goes into the ascending order all the way to the aortic root. But here in the first lumen enhances better than the true lumen. And you can see that is the case because if we look carefully, the two lumen communicates directly with the left ventricle, so it has to be the two lumen. So the question is, why does the two lumen here enhance but less well than the false lumen? Can you explain it? Any explanation?
Because the false lumen is the large one,
No.
and true lumen is in direct continuity with the.
No, that's not the explanation. I'll give you a hint. Look at the false lumen. Is it uniform? I'm showing again. It's a trickier case, so that's why I'm lingering on that one, because you can encounter this at 3 a.m. and you have to decide, and it can have implications for the patients. So, so what do you think? Why is the two lumen enhancing less well than the false lumen? The answer is just as in any other case, it depends on when you scan the patient. So as in other cases, if you scan the patient a little bit later, the enhancement will already change. So this is probably a little bit later phase of scan. So it's still arterial, but it's a later phase. So you can see that the false lumen has heterogeneous appearance, and it means there's already been some mixing. So a lot of the contrast has already passed forward, and that's why the two lumen enhances less well. Okay, so always think when you evaluate the scan, which phase I am. It's not just the location, it's also the timing that we scan the patient. Just like in other parts of the body, for example, the liver, if you have a hemangioma, it will look different in every phase. And that's why, because it changes over time. So let's talk about aortic dissection. So basically, it's the commonest form of acute aortic syndrome, and the commonest cause is hypertension. And we have to remember, if the aortic foot is involved, we have to take care of the coronary arteries, because they can be involved as well. And this could induce acute coronary syndrome. And again, as I said before, the appearance of the dissection and the false lumen will depend on the phase of the scan. We have another interesting case. So this is a simple cardiac, and just as a warm up. I'm showing this again. And the question is, what is the finding, and what do you want to do? I'm showing the scan again. Yes. Anybody?
Chronic thrombosis of lab.
Okay. You think chronic thrombosis? Maybe. Does anybody else think differently?
Or severe stenosis occlusion mid-lab.
Yeah, those were what I was
So,
between.
so I think it's severe stenosis versus even occlusion of the middle ED. And you can see that the plaque is so bad, it's essentially a mixed plaque. And it's so severe that you barely see any contrast going through. The fact that the vessel upstream doesn't hinge maybe hints to the fact that it is not a complete occlusion, but it's definitely at least a severe one, or the vessel is filled up by collaterals. And what would you recommend for this patient? What kind of a tool will help you evaluate the patient further? What kind of a modern tool do you have? Has anybody heard about a CTFFR? So basically, this is quite a severe, even at least categorized 4. And it requires immediate notification for that because the patient can be actually have impending heart attack. And you can use CTFFR for further evaluation because it will show you either in that the vessel is actually occluded or it is a very high grade ischemia. And then it can be an adjunct tool to decide on catheterization. There's another coronary case. This finding is this case is tricky. I will show you once again before I go to the questions. Okay. So what is the finding? Anyone has a good guess?
I want to say it's a dissection, but it's so subtle, and we rarely get to actually see them.
It's very subtle. It's a very subtle, and yes, it's a dissection. So if I'll show you in the bigger image, so you can see that there's a very fine flap here. If you look carefully, this is a flap in the proximal circumflex. And as you can see, if I had to ask you, is it a young or older patient?
Young.
Why?
No plaques or calcification.
So
ectatic vessel.
see how big it is, how well it dilates, and there are no calcification, there's no other finding. And so it's true that I showed you only one vessel, and I didn't show you any other vessels, and I didn't show you the calcium score or anything else. But this is a young patient. So you can see that there's a small dissection flap. So this is the section, and as Dr. Weber said, it's quite rare. It's not common at all, but it is an important finding to notice, and it's a rare cause of acute coronary syndrome, usually in younger patients that are otherwise healthy. For some reason, women are more susceptible for developing this complication than men. Usually it's idiopathic, but some conditions can be associated with that. So basically, if you have a patient who has fibromuscular dysplasia, or is pregnant or in the postpartum phase, or even patients who have connective tissue disease such as Marfan. So those are the patients that you have to be very vigilant about if they come with the chest pain, and you have to think about it, and you have, because if you don't think about it, you won't look for it. So or you won't, the clinician will not think about ordering this important scan to find this finding. We have another case. So what do you think? Does anybody have any idea?
I think it's an anomalous RCA with intraarterial course.
Excellent. That's right. So we have an anomalous RCA course with interarterial course. So if it's usually the RCA is naturally coming from the right corner cusp, but in this case we can see that it's coming from the left corner cusp, and it courses between the aorta and the main pulmonary artery. This can pose a serious problem because the vessel is actually caught up between two arteries with systemic high pressures. So, so when we talk about the anomalous course of coronaries, so as I said before, the RCA comes from the right corner cusps. The left main comes from the left corner cusps. We have an anomalous course whenever one of the corners comes from a different place. So for example, sometimes the LED can come from the right corner cusp. What matters is less the origin of the vessel, or often it matters a little less, but the course of the artery matters more. So this is the aorta, this is the pulmonary artery. If the course is in between, that can affect the hemodynamics of the vessel and can induce ischemia. But there are other causes possible. So sometimes it can cause before or anterior to the pulmonary artery, which means it is a prepulmonic cause. Sometimes it can go behind the aorta, and it will be a retro-aortic cause. These causes are not are considered benign; they're not malignant. And there's an additional transeptal that is less depicted here, but there's a third one that is also not benign, not malignant. Whenever we have that malignant cause, it can cause life-threatening ischemia or arrhythmias, and that is actually one of the causes for sudden cardiac death in younger individuals. So sometimes when we have a malignant cause, we can reimplant the anomalous artery or the other surgical solutions, but we really have to notice it because it can be a serious problem for the patients. We have another case. One more time. Okay. So what is the finding? I'm showing again with the options.
RCA fistula?
Well,
I don't see the fistula very well, but the RCA is diffusely enlarged, so I'm assuming there's a arteriovenous fistula involving the RCA.
So the RCA fistulizes into the coronary sinus, and it is difficult to see it here, but look at the vessel here. It will come up in a second. So you see it, so it's really difficult to see it here. But you're correct, it's the RCA fistula into the coronary sinus, so you can see that the RCA is very dilated. And it's because what happened is this is the fistula into the coronary sinus, right? I'll show you again. It's difficult to see it on a video without this scrolling, but the fistula is about here. See here? This is the coronary sinus going into the right atrium. So this is, so you can see that there was the RCA is getting very dilated. So basically, the biggest problem with this finding is that you have a left to right shunt, because what happens is that all the blood goes into the right atrium, and then it goes into the pulmonary circulation to the pulmonary artery to the left system, and then again into the right system. So that's why we can see that not only is the RCA dilated, look at the pulmonary artery. Look at how big it is. So over time, this can cause heart failure. So this is RCA to coronary sinus. So these are quite rare anomalies, and they usually occur between coronary artery and the right cardiac circulation, so basically it's the left to right shunt. Commonest, so in that case, commonest origin RCA and or LED. And commonest drainage is either directly into the right ventricle, right atrium, or sometimes to the pulmonary artery. The complication will be pulmonary hypertension, as in that case, where we saw the very big pulmonary artery, and eventually that will cause copulmonary. And in addition, it can cause also ischemia. because what happens is when we have blood flow that directs from the coronary into and back into the right heart without perfusing the myocardium, it can cause ischemia. And the other thing that can complicate this is endocarditis. We have one last case. Anybody? It's a difficult case. It's a very difficult one. So
This one also looks like an anomalous RCA, like with a normal aortic valve. Like I'm not seeing findings of a bioprosthetic aortic valve.
So
Like
that
right there,
one,
like there's a split like of the origin of the RCA.
one second. I think the RTA was normal. Yeah. Anyway,
No, go
that
back to
was
the origin.
yeah. Actually, yeah. So this is the case that happened.
Oh, okay.
Yeah.
Was it a different case? Sorry.
Yeah, probably.
Okay.
Maybe it's misplaced.
Oh,
Anyway,
that's
you
okay.
can see that the capacity there was a enhancement in the aortic valve, and you can see that there was probably a small abscess. And if you look here, look at how thickened the aortic valve is, and you can see that it could be a small abscess. And if you look here, so this is you see. So if you look at this is actually the correct one. So you can see that there's a lot of tissue in the aortic valve, and you can see that there's probably a small abscess, and as you can see better on the PET-CT. It's the second case I saw that in my career. The other one was in my previous hospital. So that's how it looks like. And this is the prostatic valve that is very thickened, and yeah. So bioprostatic valve endocarditis. So basically, any foreign body that is in any part can actually provide a biofilm for infections. And the main complications are embolic phenomena, abscesses, dehiscence, and myocardic aneurysms. And we really need to identify this and treat it promptly. And that's it for the current. Any questions?
That was a great case. Those are all great cases. Thank you, Gilad.
Thank you.
Of course. Anyone else? Awesome. Thank you so much for hosting the NASCI Curious Cases this week.
Thank you.
Yeah. Have a great day.
Thank you very much, Claude.
You too. Bye.
Bye.